So this podcast will be used to help you prepare for the prior authorization and third parties lab in the Ideals course. The goal of this lab is to help you lay a foundation for a systematic approach to insurance challenges that you'll see in the community pharmacy setting. So, development of a clinical decision-making process for potential alternative therapies when you get an insurance rejection, developing the ability to critically think to solve problems that you'll encounter in the community setting, and being able to explain situations to patients. A lot of patients really don't understand their insurance and what their benefits are and the exact structure of it, especially around this time of year in January and February when patients are having new plans. Sometimes they don't always pay attention to when their employers send out information and don't realize that their plans have changed, or their plans might not give them a ton of information. So they'll have increased costs and changes in costs that they'll really struggle to understand, and being able to explain that to them is really crucial for customer service and for that patient getting therapy that they need. So hopefully you'll be able to understand a little bit of the structure of our healthcare system and third parties in the United States. This will provide an introduction to managed care and pharmacy benefit managers. We'll also describe the purpose of prior authorization. So what are these? Why were they created? What is their goal? And then we'll also talk about some other third-party issues that you'll see in community pharmacies to try and get you prepared for those. So you'll review a patient drug history and an insurance message that's a rejection message to try and triage what's going on in that situation. You'll also do a third-party audit that you'll see in the community pharmacy setting to gain a little familiarity with that. So when you come to lab, you'll come for 2 hours that day, and you'll need to sit with your learning groups, and you'll work with your learning groups. You'll have a packet. You'll work through a REMS case, which we'll talk during this lecture about what that means. You'll also have 4 audit cases that you'll work through with your group. You'll then work through 1 insurance rejection case and 1 prior authorization case as well. So the objectives for this lab sort of bounce back to what are some of the things I talked about in the intro, but to define the purpose and structure of pharmacy benefit managers, also to discuss potential insurance challenges and restrictions that we'll encounter in the community pharmacy setting, to describe the purpose of insurance audits, and then to help you develop a problem-based approach to resolve common insurance scenarios. And again, this Vodcast is hopefully giving you a little background and comfort for what you'll be expected to do during that 2-hour time within lab. So references are listed here, and just a little bit of background on third-party payers for you. So these really started to kind of come to the forefront of care in about 1980 or so. Most patients prior to that time did not have pharmacy insurance, or their pharmacy benefits were actually handled through their major medical benefit. So patients would pay for all their prescriptions up front, and then they would submit receipts through their insurance company, through their medical coverage, and would be sort of on the hook for whatever that insurance company wanted to pay. Our third-party payers are responsible for about 80% of payments, was the last published amount. I think it's probably closer to 90% of payments now. And then patients will contribute to some of that payment via cost sharing, and we'll talk about some of those mechanisms a little bit later. The third-party payers have greatly affected patients' access to and expenditures for prescriptions. I would say that most patients have a lot greater of access because of that reduced cost on the patient side, and then they're probably more likely to have greater expenditure as a result of third-party payers. Our third-party payers have also had significant impact on the reimbursement to pharmacies for prescriptions and services provided to patients. Pharmacy went from a primarily cash-based to now a primarily third-party base, where they're waiting 30 to 60 days to get payment, and then they also have much less control on the reimbursement that they get. So whenever you have a private pay patient or a cash patient, the pharmacy can charge what they think is a fair price based on their cost to get the drug, overhead costs, dispensing fees, etc. But whenever you're submitting claims to a third-party payer or an insurance company, the pharmacy is sort of set on paying the cost that's determined in their contract, and a lot of times pharmacies don't have much negotiating power for that contract, or they might not know the specifics because most pharmacies have a buying group that sort of negotiates that price for the 1,000 or 2,000 pharmacies that are within that buying group. As I mentioned, most are going to reimburse via a retrospective fee-for-service method, so there's a significant delay in payment. And then there's going to be a reimbursement for the product, so the drug, as well as a dispensing fee. And that's designed to cover the bottle, the label, turning on the lights in the pharmacy, as well as sort of the cognitive services of a pharmacist. But a lot of times that fee is very, very low and doesn't adequately cover any costs associated with the pharmacy. And it's estimated that dealing with these third-party issues, submitting claims, processing claims, dealing with the prior authorizations takes up to 20% of pharmacy personnel time. So the primary third-party payers that you're going to see in a community pharmacy setting are going to generally be our government payers, so Medicare and Medicaid. As a refresher, Medicare is a federal program for individuals of retirement age, so those are 65 and older. Sometimes some specialized conditions, so if people are disabled, if they have end-stage renal disease, then they would be eligible. And that's going to cover outpatient prescription drug benefits. So anytime you have a patient who says that they're Medicare, you need to ask for their Part D. I've had countless patients who have come into me in the community setting and have presented their Medicare Part B coverage. So that's something that patients get confused about a lot. Occasionally, you'll process Medicare Part B in a community pharmacy setting. Sometimes for a few immunizations that'll be covered under Part B, such as influenza, or patients who have certain chronic health conditions, like if they've had a kidney transplant, their transplant medications will actually be covered under Part B. Medicaid is in a joint federal and state program for low-income individuals, provides coverage for outpatient prescriptions, and this was expanded significantly with the Patient Protection and Affordable Care Act of 2010. Oversight for both of these is provided by the CMS, or Centers for Medicare and Medicaid Services, and low-income elderly patients can be dual eligible, so you might have to process both of those insurances within the community pharmacy setting if they're older patient populations. Talking about Medicare a little bit more. So again, Part D is going to be your drug benefit. There's Part A, B, and then C and D as well. So patients, like I said, are really confused generally about Medicare. They don't really understand what part covers what. And so patients must separately enroll in a standalone prescription drug plan or a Medicare Advantage plan that provides combined coverage. These plans are approved and regulated by Medicare, but they're actually operated by private health insurance companies. So they submit bids to Medicare, and then Medicare selects which ones they want to administer. And so patients will have a Blue Cross Blue Shield or United Healthcare type of drug card for their Medicare prescription coverage. Patients will have an annual premium for these, and then coverage is not standardized. CMS has certain requirements that these plans must provide, but they'll look different. So one patient's copayments can be different from another patient's copayments. Now we'll move into pharmacy benefit managers because that's where the main focus of this lab, prior authorizations, really came from. So from now on, I'll refer to these as PBMs. I'm sure you've heard a lot of things about them and probably not super great things within the media. They were developed within the late 1970s as we started having more and more patients who had drug plans and who also were taking a significant number of medications. And so before this time, like I said, patients would pay for their drugs usually and then would submit receipts to their medical plans, and it was a very cumbersome process. And so these were designed to sort of manage and administer the prescription drug side of insuring lives, and they were supposed to negotiate more affordable prices for those insurers. And what sort of happened along the way is those sharings, because of a larger buying group through these PBMs, are not always shared with the insurers. So the pharmacy benefit manager is a separate entity from the insurer. So, for example, for ETSU, we have insurance through Blue Cross Blue Shield of Tennessee. Blue Cross Blue Shield of Tennessee, I pay a specific premium each month for them to provide pharmacy benefits for me, and they then send that amount that I pay each month to CVS Caremark, who is my pharmacy benefit manager. So they get a specific pot of money to provide any prescription benefits I may need each month, a lot of times, which doesn't get used, and they then get to keep that sort of pot of money to cover other people who might use larger amounts of prescription drug benefits. And so PBMs have sort of what's called a spread. So they'll say for an amoxicillin prescription, for example, it's going to cost $80 to provide that for me. When in reality, it probably costs $20 or $30 that they're actually sending to the pharmacy, and then they keep that $50 sort of in their pot, and that's how PBMs have become $20 or $30 billion companies and have become these major Fortune 500 companies, is that $50 is called a spread that they often keep for themselves. But these PBMs contract with pharmacies to develop a network. So that would be pharmacies patients are able to go to and get their prescriptions filled. And then these PBMs also commonly receive rebates from pharmaceutical manufacturers. So Pfizer, for example, and those can either be based on Pfizer's Lipitor a few years ago when it was still branded, being placed on a formulary, or if a PBM fills a certain quantity. Nexium, that was a great example a few years ago when that was branded. They fill 3,000 Nexium scripts a month. They get a certain rebate off of their purchase price from that drug manufacturer. So formularies are something that's important to understand for this lab. These were again designed to be sort of a cost containment strategy by our PBMs. And formularies are a list of medications that are going to be covered by insurers. They're typically categorized into tiers. The most common that I've probably seen is 4-tier, but there can be anywhere from 2-tier, where there's just a generic tier, and then a brand tier, all the way up to 5 tiers, where they have generics, preferred and non-preferred brands, specialty medications, and then lifestyle medications as well. The higher tier you go, the higher copayment a patient is going to have. All right, so formularies for Medicare Part D, these are heavily regulated by CMS. They review and approve all formularies for their PBMs that are offering Medicare Part D plans to Medicare beneficiaries. And generally, these must include all or substantially all antidepressants, antipsychotics, anticonvulsants, anti-cancer, immunosuppressants, and HIV or AIDS medications. So the next thing that we'll talk about to prepare you for the lab is patient cost sharing. These are going to be additional things that you'll need to understand in order to make alternative selections in the cases that you'll see, and they're really important to understand, again, for that patient counseling piece. So hopefully, walking away from this lab, one of the biggest things that you'll gain is being able to explain some of these terms to patients, because a lot of them really don't understand sort of what's going on. And even for myself this past year during open enrollment, ETSU offered 4 different medical plans that were all vastly different. So I spent a significant portion of one evening looking at each of the plans, working through what these costs were, what these patient cost sharing mechanisms would look like, and trying to figure out which plan was the best. So for even myself, someone who teaches insurance concepts and who is a healthcare practitioner, it was sort of an overwhelming process. So these cost sharing mechanisms have 2 purposes. One, there's the patient portion to reduce the plan's portion of cost, so it's sort of a cost-saving mechanism for the plan, but also they were designed for patients to try and be more responsible or more engaged in their use of medications. So if they're paying a portion of the cost, they're likely to use less medications because they're only going to purchase medications that they think they actually need, and then hopefully they'll become more adherent as well because they're invested in the cost of the medication. So the first term is a copayment. That's one that you're probably most familiar with. So a patient's going to pay a fixed dollar amount per prescription, and that again is generally going to be based off of the tier that drug falls on a medication's formulary status or a plan's formulary. The next term is coinsurance, and this is one that patients struggle with a lot more. And it's very similar to a copayment, but instead of a fixed dollar amount, the patient pays a fixed percentage of each prescription cost, and that's generally about 10 to 20% per prescription. The next is deductible, and again, this is one that you'll struggle with a lot during January and February. Many patients forget that they have a deductible that's separate from their medical plan for pharmacy plans. And so what a deductible is a patient has to pay for a specified amount of coverage before their prescription benefit starts to cover any expenses. So that may be $200 or $300. It may be $1,000 for some of these plans, especially if people enroll via the insurance marketplace. So whatever that amount is, they have to pay that completely out of pocket before their insurance will start to pay. And then one that you'll see occasionally, but you don't see as much, as a maximum payment amount. And so the third-party payer will pay a limited amount for a patient's prescriptions during the year. And once they reach that amount, they won't pay anymore. So looking at Medicare, because again, that's where most of your patients are going to fall, and a lot of Medicare patients really don't know what these amounts are. So beginning of the year, usually about middle of the year, you'll have some disgruntled patients a lot of times in the community pharmacy setting because they're being hit with unexpected costs. So Medicare has an additional deductible, so that's the total amount a beneficiary has to pay before benefits will begin, and that typically is going to be $360 in 2016. And these are all determined by Medicare. Each year you can go to medicare.gov during open enrollment and sort of provide patients with that expectation of what that amount's going to be. So initial coverage limit is the sum of the beneficiary's out-of-pocket expenses and the drug plan's costs. And so once they reach this, they'll enter what's called the gap phase, or a donut hole. And during the donut hole, patients are responsible for 100% of their drug costs. For whatever reason, this has been around since Medicare Part D came out in 2016 or went live, but patients are always blindsided by what's called the donut hole. And so this amount for 2016 is $3,310. So once a patient between themselves and their drug plan has spent that amount, they have to pay 100% of their costs. Patients then have a total out-of-pocket expense, and so that's the total amount that they accrue from the start of the year until they reach that limit, and so that allows them to leave the gap phase or the donut hole. And so that's $4,850 or $4,850. And once they reach that drug spend, they'll be in catastrophic coverage, which is significantly reduced drug plan costs or drug plan co-payments for patients. And those amounts are listed here on the slides for you. All right, so now moving on to prior authorizations. Again, the main focus of this lab. This is a very cumbersome and complex process within the community pharmacy setting that a lot of patients really don't understand the process at all. And so these were designed by our PBMs to try and be sort of a cost containment strategy. They allow access to certain medications who meet specified criteria. So there's a extra step before determination if an insurance provider will cover. So what I try and tell patients is the insurance company wants more information before they decide if they're going to pay for a drug or not. So this actually falls on the prescriber. So the prescriber must get approval from the plan prior to patients receiving the medication, but it usually starts in the community pharmacy setting because patients and prescribers don't really know what's on a prior authorization list. For patients, they don't always know where to go to get that information. For prescribers, they have generally thousands of patients within an office, which means hundreds of different plans, and so it's just not feasible for them to always know what medications are going to receive a prior authorization or not. So what will happen is a pharmacy will receive an electronic rejection message when processing the prescription. So when they send it up to what's called the switch, and that's when they send it to the insurance company to try and get approval for it. And then renewal of these authorizations is typically required. So usually a prior authorization will last a year. So if a patient says, well, my plan covered it before, I don't understand why they're not now, it may be that their prior authorization has expired and just needs renewed. So for prior authorizations, They were designed to try and optimize patient outcomes and using medications with established safety and efficacy while providing highest value. So they're sort of a double-edged sword. They are cost containment, so they're trying to use cost-effective medications that are generic, more affordable brand medications that PBM may have a rebate for. But we're also trying to bring some evidence-based medicine and some medications that have consistent evidence in clinical trials of showing reduction of adverse outcomes for whatever condition we're treating. Ideally, these should ensure that patients receive the most appropriate medication while reducing error, waste, and unnecessary prescription drug use and cost. Procedures and requirements for coverage are supposed to be based on clinical need and therapeutic rationale. Sometimes they are, and sometimes the PBMs get a little loose with that terminology. The guidelines and policies for which medications require prior authorizations and how to get it approved for prior authorization are determined by pharmacists and other qualified healthcare professionals that work for that managed care organization or that pharmacy benefit manager organization. And they really address the need to obtain clinical information. And you'll see that during the lab is sometimes they want to know what the patient's A1C is before they're going to cover an expensive diabetes medication. For some of our more expensive statin medications now that are termed high dose, they want to see what the patient has been on before. Medications that are likely to have prior authorizations are listed here. This is just sort of an expectation for you for ones that you might see them a lot. Ones that I've seen consistently are lifestyle medications, so Cialis and Viagra are typically not covered. Sometimes acne medications can fall under there. Medications that have a high potential for serious side effects or interactions as well can fall under this. And so this just, again, provides some more examples for you. All right, so when you have a prior authorization, how should you counsel the patient within the community pharmacy setting? What should their next steps be? So I always try and pull the patient out of the workflow a little bit into the counseling area of the pharmacy and spend a few minutes explaining this to them. Making sure, again, that you sort of go back to what is the purpose of this. So their insurance companies trying to gather more information to decide if they want to provide coverage for this medication or not. They may want them to try another medication first. So the first thing I tell the patient is to contact the prescriber and let them know that the medication requires a prior authorization. The pharmacy is, again, going to get that information in the rejection message, and then you should send that paperwork on to the prescriber. I also tell the patient to ask the doctor's office how long it typically takes for them to contact the insurance company and complete the required paperwork. You always want to give people sort of a frame of mind of how long this is going to take, because a lot of their frustration with the prior authorization process is that it was an unexpected delay. And so if you can try and give them a true timeline, usually there's less of a customer service issue there. It also might be helpful for them to be instructed to contact their insurance company and see if there's any additional steps or paperwork that they may need to complete. Making sure that they actually allow time. These are generally not quick processes. Some of them, if they're sort of more urgent needs, so Tamiflu, for example, for influenza, many insurance companies have a PA for those, but because of the timeliness of getting that therapy to patients, once it's submitted, they'll review it within 24 hours. However, most medications are probably about 48, on a good case, 72 hours for once that paperwork is actually submitted to the insurance company, that they'll review it and make a decision. And then that doctor's office is probably going to need 24 to 48 business hours as well to get their documentation to the insurance company. You want to instruct the patient to check back with the pharmacy to see if the prior authorization was completed. And if the pharmacy hasn't sort of received updates, the patient didn't get approved for the prior authorization, they may want to call the insurance company to understand why it was not approved. All right, so prior authorization results. There's a few different things that can happen. Sometimes they're just not going to be approved. So generic substitution may be mandatory. If a prescriber writes for Prevacid, the insurance company may require that they switch to a generic PPI instead. Or certain generics might have lower copayments than others if they're a more cost-effective generic. Quantity limits can also be a result that you'll see as well. So a lot of opioids and long-acting opioids will have quantity limits. So the medication will be covered, but they limit it to a certain number of dosage units per day or a certain number of days supply per month or per prescription, and so the patient might get part of it covered but might have to cover a part of that out of their own pocket as well. Sometimes you can see mail order be required, and that results in a lower copayment for patients, or the patient may be able to obtain a greater quantity by using mail service or mail order. Step therapy is going to be one that you'll see a lot with prior authorization. So the computer, when you submit that claim, will perform an automated review of the patient's drug history to see if preferred alternatives have been utilized first. If they don't see that within their fill history for the patient, they'll generally submit or send back that prior authorization to you. The goal of step therapy is to ensure clinically sound and cost-effective treatments are tried before the most expensive drugs are prescribed. And so what that's requiring is clinically recognized first-line therapy, so drugs that we have evidence of benefit, as well as drugs that are generally cost-effective being used before that second-line drug is approved. So 9.9 times out of 10, that medication will not be covered unless the patient meets the requirements of the step therapy, so they've tried 2 generic NSAIDs before Celebrex will be covered, for example. Once step therapy has been completed, though, it usually is covered as long as the prescriber attests the required therapeutic benefit has not been achieved. So in that form, they'll have to put the dates that the patient tried those step therapy medications, as well as why the patient failed the therapy. All right, so Cover My Meds is the last thing we'll talk about with prior authorization. Just something I wanted to make you aware of. It is an electronic prior authorization program. It was founded in 2008 to try and automate this prior authorization process and make it a little bit smoother for everyone involved. So there's significant workload involved for the pharmacies and the doctor's offices as well. And so they're trying to streamline it to make it easier, to sort of diminish some of that workload, and hopefully trying to get patients access to needed therapy quicker as well. The really nice thing about this is it's secure and HIPAA compliant, so there's no worries there. And it's financially supported by drug manufacturers and the third-party payers. So there's no cost for the pharmacy or the prescriber to use this. Within the Cover My Meds system, it'll initiate, transmit, and track the status of a claim, and it actually integrates with EHR records, which is really nice. Within pharmacy systems, there's a little bit of an extra step. At least whenever I was a resident, we had to go to their website and sort of connect there, but our pharmacy software system sent the rejection message and associated paperwork to their website automatically. Okay, so for the next part of your lab, adjudication management, this is sort of the insurance rejection piece. So each time you process a prescription, it sends it to what's called the switch. There's a fee associated with that. It's about 8 to 11 cents if I remember correctly. And this provides a real-time connection with the insurance company to determine if a prescription is going to be covered, as well as the copayment associated with it. So when you're processing claims, it's really important to ensure you're entering the correct ID, patient modifier. So for a child, for example, that's under a mother's insurance, they're generally going to be O2 or O3 that you have to add on to that patient ID. And then the group number and any other type of information that may be required. Because if you enter it incorrectly, it's going to reject that the patient's not covered, which is a sort of burdensome process to you because you try and figure out why is this rejecting, and then each time you submit, you're racking up those fees. When you receive a rejection notice, it'll commonly provide guidance as to why it was rejected, so it may say days supply incorrect. So if you have an 80-gram tube of a medication and you put that it is only a 14-day supply. It's generally too much product for that time. It also may be maximum quantity, so they're only going to cover X tablets for a 30-day supply. It may go back to that prior authorization piece. Maybe a refill too soon, and it'll typically provide the last date it was filled, as well as the pharmacy it was filled at. You might get patient not covered or incorrect identifier, as well as coverage not active. So your insurance rejection case will provide some of that information for you, and then you have to determine how's the most appropriate way to handle it. So if it comes back refilled too soon, maybe the patient recently increased dosage and they went from lisinopril 20 milligrams a day to 40 milligrams a day. We're taking 2 of their 20 milligrams because they already had it. So some of those thought processes of why does this look incorrect and what do I need to do to fix it so that my patient gets therapy. And it might be that you can't fix it. Sometimes for maximum quantity, like I said, a lot of pain medications have a maximum quantity that the insurance company simply just isn't going to cover any more than 90 tablets for 30 days. The next lab case that you'll see is a prescription audit, and these are seen a lot in the community pharmacy setting. And it's something that I didn't see at all until I was an intern or until I was a pharmacy resident. So I wanted to provide a little bit of familiarity with you. There's 2 types of audits you can see. There's desk audits where they just review claims data to make sure that things are appropriately queued, day supply is correct, right product was filled when looking at the hard copy image, etc. And they don't come to the pharmacy. Field audits are when the third-party representative actually comes to the pharmacy. They'll email the pharmacy owner or PIC in advance, tell them that they want to see prescription 6,000 through prescription 6,300, and to have those out and ready on X date. Generally, they're supposed to give 14 days notice, and they'll expect the pharmacy records as well as the procedures. These are designed to ensure prescription procedures and reimbursement mechanisms are consistent with what's in the contract. So what the contract says you agree to whenever you're processing prescriptions, as well as regulatory requirements. So what the laws, both at the federal level and the state level, require. So they should be just a quality control mechanism. But what they've become through the years is an abusive way to take back money for claims or for prescriptions that were filled from a third-party benefit manager. And they do a lot of what's called extrapolation. So if they look at 100 prescriptions, they find 5 errors. They extrapolate 5% of the prescriptions that you filled for a 2-year time period were incorrectly filled, and they take 5% of your profit or sort of your reimbursement back from you. So I always encourage students to pay high attention to what seems trivial. So days supply. So if you have, again, a tube of 80-gram hydrocortisone and you put a 14-day supply, they're probably going to either say you should have filled it with a smaller tube or that you should have had a larger day supply. Making sure you use the right dosage form. So if a product is written for an ointment and you fill for a cream, that's something that they can easily target for an audit. Date written, making sure that that's correct, it's not a day off, as well as strength. If a prescription doesn't have a listed strength, unless it's available in only one strength, you should always call and verify, even if the patient's been on it before. So I wanted to provide a few examples for you so you can feel a little bit more comfortable in the lab. So as you can see here, we have Paul McCartney, who is written for hydrocortisone cream, applying a thin film to affected areas twice a day for 1 week, written for a quantity of 1. On the right, you'll see the back label. So we filled with hydrocortisone acetonide, 0.1% cream, 7 grams, applying a thin film to affected area twice daily for a week. When you look at the actual fill record, it shows that we filled for 80 grams. So 80 grams for a 1 week supply is probably too large, so we should select a smaller quantity like a 15-gram tube. Hydrocortisone actually comes in a few different salt formations, so that's one that I'll always call on because that's a huge target for auditing that I didn't verify which salt product they wanted. Also a quantity of 1 can be a target for auditing, so using your best judgment of either selecting the smallest size, so 15 grams, or calling the office to verify. Alright, so REMS is the last thing that we'll talk about. What that stands for is Risk Evaluation and Mitigation Strategies. This was approved by the FDA in 2007 as a result of some medications getting approved that had some serious safety concerns associated with them and trying to make them safer to use. And so the goal is to weigh risk versus benefits for certain medications and biologic procedures. The ultimate goal of these is patient safety. So they're trying to provide safe access to medications that have some significant risk for patients that without these REMS components, the FDA would not have approved them, but they believe certain patient populations that the benefits outweigh the risks. So the FDA sent out a letter to manufacturers stating that REMS will include the following. It may include as little as just one of these, so some medications only require the medication guide, or it may require all of them. It all just depends on what the potential side effect or risk associated with the medication may be. A lot of them will have healthcare provider training for those who prescribe the products, so some of our long-acting opioids fall under that now, trying to make sure our prescribers really understand how these drugs work and how to prescribe them safely. And there can also be information for prescribers on educating patients on storage, safe use, and disposal, announcement of these requirements to prescribers, assessments, evaluations, and surveillance, so sort of monitoring systems. And then there are also instructions for companies to create a single shared system. So that's for medications that are available generically. So isotretinoin is an example of that. They require that they make one system versus 5 or 10 different systems based on which generic manufacturer you're looking at. So this shows just all the different pieces there may be within the REMS, from least restrictive to most. So medication guides and communication plans are the least restrictive. That's simply providing education to patients about a medication, to most restrictive being managed distribution. So some medications are only available through certain wholesalers or through certain mail order pharmacies to try and make sure that people handling those medications really know how to safely use that medication in a patient population. All of the medications that have REMS components are listed on the FDA website as seen here. And on that website, it not only includes the medication, but it also provides a detail of what the REMS requirements are for that medication. So a sample REMS is shown here. That's for Qsymia. It was a new drug that was approved in 2013. And the main reason that we have REMS for this medication is there's some teratogenic side effects of this medication. And it's a weight loss medication, so women are generally the most likely patient population to use this. And it has some birth defects that occur during the first trimester of pregnancy, often when women may not be aware that they're pregnant yet. And so that's why there's REMS for this medication. So the requirements for this are a medication guide that must be provided at each dispensing, and most pharmacy processing systems will have it so that it automatically prints whenever you fill that prescription. It also has elements to assure safe use. And so there's training that must be completed by prescribers before they can prescribe this medication, and the company maintains a database of all providers who have completed the training. They compare their monthly dispensing records of certified pharmacies and then contact prescribers who are not in the database but who have a record of dispensing this. They also are required to inform registered prescribers of any updates. And I found all this information from that FDA website. So during the lab, you'll have a medication in which you'll have to discuss some of the REMS components of that medication. You'll want to bring your computer to lab because there will be some information on D2L for that REMS guide that you can use, either the information I've posted or the FDA website as well. Additional requirements under that elements to assure safe use as each pharmacy must designate an authorized representative to coordinate and oversee the REMS program, so they make sure that the pharmacy staff are all educated on the requirements. There's an implementation system, so the manufacturer must monitor and evaluate if the elements to assure safe use are meeting the program's goals. And then they also have a timetable for submission of assessments. And so this just shows the website. As you go to QSIMIA, they have a healthcare provider section that discusses the REMS requirements. Most manufacturers will have something similar to this. They also have a login for pharmacies so that they can complete their training for their program coordinator, and then also so that they can sort of fill out their requirements as well. And then patients can search for a certified pharmacy near them. So any pharmacy is eligible, but they must have someone complete this training for them to be certified. QSIMIA was originally available only through mail order, so through Walgreens and Walmart Pharmacy, and then it was expanded to any community pharmacy that wanted to become certified. So if you have any questions or concerns before the lab, please feel free to email me. Again, you'll come with your learning group. Times will be posted on the D2L by Dr. Flores. You'll be in lab for 2 hours, and we'll have 4 different types of cases that you'll need to complete during that time.